Hello everyone. First, I would like to express my sincere appreciation to WFN and AOAN for the kind invitation and allowing me the honor of being a part of this e-learning day. I'm Dr. Nam-Jong Paik, serving as the President-elect of the WFNR and a professor at Seoul National University, Bundang Hospital. My talk today is Recent Technology Adoption in Stroke Neurorehabilitation. Here is the outline of my lecture. I'll commence with the topic of robotic rehabilitation. Robots can be classified into exoskeleton type or end-effector type depending on the terminal device. Locomet for lower limb and Armio Power for upper limb are exoskeleton type, and Geosystem for lower limb and InMotion for upper limb are end-effector type. For ambulatory robot, Restore, which is soft exosuit, has been FDA approval for stroke gait training. Typically, these devices got FDA approval as a Class 2 medical device. These are the advantages of robotic-assisted rehabilitation. It provides high-intensity, repetitive, task-oriented, and task-specific training. It provides high precision and endurance. It can be standardized, and it motivates patients using training context. It provides real-time feedback, and it can be adjustable, and it can provide objective measures, and it can be adapted to all levels of ability. Sometimes it may be cost-effective depending on the reimbursement system. We conducted a multi-center trial to demonstrate the performance of the ExoWalk, an exoskeleton-type gait trainer designed to replicate certain dynamic mobility functions. Briefly, our finding indicated that the electromechanical assisted gait training proved to be equally effective as the traditional gait training involving a physiotherapist. Notably, the outcomes in both groups demonstrate a high degree of comparability. In our subgroup analysis of stroke duration of 90 days, the subacute group displayed notable improvement in clinical walking functions when compared to the chronic group. In a recent Cochrane review, it was shown that people who receive electromechanical assisted gait training in combination with physiotherapy after stroke are more likely to achieve independent walking than people who receive gait training without these devices. People in the first 3 months after stroke and those who are not able to walk seem to benefit most from this type of intervention. However, the role of the type of device is still not clear. Based on our current understanding grounded in evidence-based research, we can identify optimal candidates for robot-assisted gait training. These candidates include individuals falling into two categories. Number 1, individuals unable to walk. Those who fall under functional ambulation category 0 or 1, signifying a complete lack of independent ambulation capability or a minimal ability to walk with assistance, are excellent candidates. Number 2, it is important to emphasize the relevance of timing. The ideal window for such intervention typically lies within the initial 3 months following a stroke, during which patients may experience substantial gains in their rehab journey through the use of these robotic systems. In 2010, a significant multicenter randomized controlled trial conducted by Low et al. Delved into the realm of robot-assisted upper arm therapeutic training. The patients were assigned to one of 3 groups: intensive robot-assisted therapy, intensive comparison therapy, or usual care. it was observed that at the 12-week mark, robot-assisted therapy did not yield a significant improvement in motor function compared to either usual care or intensive therapy. Another study conducted in Switzerland and more recent Ratul study, all the study results were negative, meaning that robot-assisted training failed to demonstrate a significant improvement in upper limb function after stroke in comparison to usual care. In a recent Cochrane review, the efficacy of electromechanical assisted arm training when coupled with physiotherapy in stroke patients was analyzed. The findings showed that individuals who underwent electromechanical and robot-assisted arm training post-stroke exhibited promising enhancement in their daily activity of living, arm function, and arm muscle strength. However, a subsequent publication emerged 2 years later. They arrived at the conclusion that the outcome achieved through robotic-assisted arm training were comparable with those achieved through conventional therapy. Moreover, when indirect comparisons were made between various types of robotic devices, there was no apparent differences in their effectiveness. A soft wearable robot, often referred to as a soft exosuit or soft exoskeleton, is a type of wearable robotic device designed to augment and assist human movement. Unlike traditional rigid exoskeletons, which typically use rigid frames and joints, soft wearable robots incorporate flexible materials and soft components such as textiles and fabric-based actuators. Soft wearable robots are typically lightweight and more comfortable to wear than their rigid counterparts. They are designed to be worn like clothing or attached to a specific body parts such as the legs and arms. These devices use sensors and actuators to detect and enhance wearers' movement. One of the key advantages of soft wearable robots is their adaptability and versatility. We developed the soft wearable robot ankle-foot orthosis for post-stroke patients. The ankle brace was fabricated using a 3D printer. Using Velcro straps, easy donning and doffing was possible. Bidirectional tendon-driven actuation module was applied. This shows wearable gait sensing modules. It measures the patient's lower limb motions at foot-ground contact and integrated with the actuation module and the real-time control system. The gait phase of patient is detected in real time based on measured foot-ground contact information and the gait motion of paretic side of the sagittal plane. This is the video of male 49 years old, left hemiplegic stroke patient walking without AFO. As you see, there is a foot drop and dragging of the left side. When patients wear a soft AFO and with orthosis actuated, foot drop was corrected and also appropriate plantar flexion was achieved at the proper moment during the gait cycle. This is a wearable hip assistant robot developed by Samsung Advanced Institute of Technology, known as the GEMS, Gait Enhancing and Motivating System. This device has the capacity to deliver supportive torque and power precisely around the bilateral hip joint, effectively assisting with both hip extension and flexion during walking. In a randomized controlled trials involving 26 stroke patients, GEMS enhanced the gait parameters and reduced the energy cost. This is an example of arm and hand orthosis designed to help restore function to the patient's paralyzed or weakened upper extremity, helping individuals perform actions and daily activities of living that might otherwise be impossible. This device detects the myoelectrical signal from the patient's surface of the skin, then activating actuators to move the limb as the user intends. In theory, this process has the potential to contribute to motor recovery through muscle re-education. By continuously engaging and exercising the musculature, the device aids in retraining the neural pathways and promoting the recovery of motor function. Furthermore, the advancement of brain-computer interface-controlled exoskeleton holds the promise of groundbreaking treatment approaches for neurorehab following a stroke, especially for patients with severe paralysis. Evidence has indicated that with regular and repetitive use over the course of several weeks, brain-computer interface-controlled robots have the potential to trigger motor recovery even in cases of chronic paralysis. This marks a significant leap in our understanding of neurorehab and the remarkable potential of technology to bring about positive change. Recent development in lightweight robotic actuators, the creation of comfortable and portable real-world brain recording solutions, and the establishment of reliable brain control strategies have collectively cleared the path for brain-computer interface-controlled soft robots to enter the realm of clinical care. These BCI-controlled soft robots have now reached the state of technical readiness, and they may play a pivotal role in enhancing the effectiveness of personalized treatment strategies. I'm pleased to introduce to you a system currently under development through our collaboration with Charité University in Berlin. This pioneering innovation takes the form of a soft robotic hand orthosis that is controlled by EEG signals. As demonstrated in the videos, with the assistance of this BCI-controlled soft robot, individuals are now capable of engaging in bimanual activities of daily living tasks that were previously beyond their reach. We postulate that this form of training, harnessing the power of brain-computer interface, has the potential to induce substantial brain plasticity and foster greater improvement in motor function compared to training without the BCI component. This hypothesis opens up a promising tool for enhancing the effectiveness of neurorehabilitation, potentially leading to more profound and lasting outcomes for our patient. Now I will proceed to virtual real aspect. Virtual rehabilitation is a method of rehab via gamification through synchronization with software contents or by providing a motion guide. VR rehab offers key benefits: immersion, real-world simulation, observation, real-time feedback, physical and cognitive focus, customization, standardization, and remote accessibility. Virtual reality can serve as an evaluation tool for assessing patient function, which is crucial for designing effective rehab plans. The box and block test, a traditional and straightforward assessment tool commonly employed in hospital settings, has previously proven its utility in stroke neurorehab. In our work, we have developed the virtual box and block test system using a standard depth sensing camera. This system can be used to assess patient function in a tele-rehab context. Comparing the results of real and virtual box and block tests revealed a strong correlation between the performance of the paretic and non-paretic arms. This highlights the potential for virtualizing and conducting unsupervised assessment of conventional tests. Such a virtual upper limb function assessment tool deployable in a home setting could be a pivotal component of a home-based virtual rehab system. We developed a Kinect-based version of Fugal Assessment tool and verified its efficacy in assessing hemiplegic stroke patients. The Fugal assessment has long been considered the gold standard for quantifying impairment in stroke patients. If it can be automatically and independently administered in a home environment, it holds great potential for monitoring patient functional progress in a tele-rehab context. We investigate the prediction accuracy for each individual's Fugal assessment item and the correlation between the actual Fugal assessment score and those obtained using a Kinect-based system. We observed high levels of prediction accuracy and strong correlation between the virtual measurement and the traditional in-person Fugal assessment. Now I'll talk on the virtual reality as therapeutic tool to improve patient function. We evaluate the efficacy of low-cost Kinect-based virtual rehabilitation program for upper limb recovery among patients with subacute stroke. We designed arm, elbow, wrist, and finger exercises and performed a double-blind randomized sham-controlled trial. In a study involving 23 subacute stroke patients, 3 groups received different therapies after daily 30 minutes occupational therapy for 10 consecutive days: real VR group, sham VR group, and control group. The outcomes of this study revealed that the VR system stimulated greater arm movement compared to the sham control group. While the improvements were not statistically significant when compared to conventional therapy, they did indicate higher patient engagement with VR games. Mobile devices such as smartphones and tablet PCs offers a platform for delivering personalized home-based therapy with interactive communications between patients and clinicians. This research project focused on the development and assessment of a mobile VR upper extremity rehab program that utilized the game application for stroke patients. According to Cochrane review conducted in 2018, it was suggested that VR therapy might not yield superior result when compared with conventional therapy in terms of upper limb outcomes. While findings in this area present some conflicting results, some of recent meta-analysis indicated that VR may offer advantages over time-matched conventional therapy in the context of upper extremity motor impairment and motor function recovery. Prism adaptation therapy stands as one of the most well-supported approaches for hemispatial neglect. We developed the virtual prism adaptation therapy system harnessing immersive VR technology in conjunction with the depth sensing camera. In this system, patients receive instructions to employ their right hand to point toward the target ball. Our initial findings suggested that the pointing errors observed with the VR adaptation therapy system closely resembled those seen in conventional therapy. This serves as an example of digital therapeutics. The integration of digital therapeutics, known as DTX, in stroke rehab represents a promising and rapid evolving trend in healthcare. This image illustrates a merged system that combines virtual reality and TDCS. Individuals with stroke can initially use this system in a hospital environment under the guidance of a clinician and subsequently continue their rehab at home with telemonitored support. From a technological perspective, the incorporation of imaging-based modeling and concurrent brain signal monitoring alongside with TDCS has the potential to enable highly personalized and optimizing targeting, promoting more favorable neuroplasticity following stroke. This system also offers real-time adjustment based on the patient brain signal. I'll present the potential for tele-rehab in stroke rehab. This serves a standard tele-rehab platform. Initially, patients can be remotely connected for assessment. This assessment can occur in either real-time or by storing and forwarding data. Subsequently, the assessment data is transmitted to the central DV. Within the central DV, a decision support system driven by preset algorithms or AI operates to deliver an automated rehab program tailored to the patient functional level through automated messages or SMS. Alternatively, this process can be guided by a healthcare provider through video conferencing. Throughout this journey, patients can engage in enjoyable activities like serious games and gamified applications. Within this platform, options like online support groups, chatbots, or conversational AIs can be integrated. In the first part of the study, we developed a reliable mobile aphasia screening test for stroke patients in remote locations. This mobile version of the Frank-Eye aphasia screening test was designed as an iPad application and was validated by comparing it with traditional assessment like the Western Aphasia Battery and the paper-based FAST. The mobile FAST proved to be a reliable and sensitive tool with good accuracy, allowing for automated aphasia testing via iPad. In the second part, we created an iPad-based tele-speech therapy program with varying difficulty levels in 6 speech domains. 8 chronic post-stroke aphasia patients participated in a 4-week therapy using this program. Pre- and post-treatment scores on the Western Aphasia Battery demonstrated significant improvement, which persisted at the 1-month follow-up. The degree of improvement was linked to the usage time and showed high overall satisfaction with the iPad platform. These results suggest that tele-speech therapy is an effective and feasible treatment for chronic aphasia regardless of age and aphasia severity. Dr. Kramer and colleagues conducted a randomized controlled trial to assess the effectiveness of tele-rehab compared to traditional in-clinic rehab therapy in improving the rehab outcomes of post-stroke patients. The study aimed to determine whether a 6-week intensive home-based tele-rehab program targeting arm movement could provide benefits similar to those achieved through traditional in-clinic rehab therapy with a matched dosage. A total of 124 post-stroke patients participated in the trial, receiving 36 sessions of dose-matched arm motor therapy in addition to stroke education. This was a randomized, accessor-blinded, non-inferiority clinical trial. The findings revealed that tele-rehab demonstrated efficacy comparable to traditional in-clinic rehab in enhancing motor function as assessed by the Fugel-Meyer Arm Motor Scale. I'd like to provide an example of telemonitoring physical activity using motion tracers, which plays a crucial role in promoting the functional recovery of stroke survivors. Accurate and convenient measurement of physical activity both during and after hospitalizations are essential for providing valuable feedback on functional status and the effectiveness of rehab interventions. A total of 24 patients in the subacute phase of stroke recovery participated in this study. These individuals wore accelerometer on their wrists and ankles for 3 consecutive weekdays. The data collected over this 3 days period exhibited excellent test-retest reliability, and the accelerometers demonstrated a strong correlation with behavioral observations regarding energy expenditure. In the future, the integration of robots into tele-rehab system holds the potential to remotely monitor patient functioning. Our study aimed to explore the feasibility of tele-assessment for elbow function, encompassing passive ROM, muscle strength, and spasticity in stroke patients using a master and slave robot system. To implement this tele-robotic system for remote assessment, we assembled a master robot which interacted with the doctor and a slave robot which interacted with the patient-affected elbow in stroke patient. Communication of real-time position and force information between the master and slave robot was facilitated through the custom-built software via the public internet. As a rigorously test of feasibility, an intercontinental remote assessment scenario was designed for clinical evaluation. For these clinical tests, stroke patients with unilateral upper limb hemiparesis were recruited. The assessing doctor was located in a laboratory in the United States, while the stroke patients were situated at our clinic in South Korea. The remote assessor, using the master robot, guided the patient who wore the slave robot through appropriate action via video conferencing. By manipulating the master robot, the remote assessor was able to perceive the resistance experienced by the patient's elbow, facilitating the comprehensive teleassessment of their elbow function. Finally, I would like to comment the artificial intelligence. Artificial intelligence plays a crucial role in analyzing patient data, enabling the identification of patterns, prediction of outcomes, and the adaptation of treatment plans. This results in more effective and efficient rehab. AI technologies are commonly integrated into tele-rehab platforms and technical devices, making it possible to extend rehab services remotely. Large language models, such as ChatGPT, are harnessed to explore the creation of tailored rehab programs. These models access extensive medical literatures and patient data to design individual treatment plans, considering each patient's unique needs, limitations, and objectives. AI-driven language models are used to monitor patient progress and offer education and support to both stroke patients and their caregivers. The ability to provide information and guidance in plain, easily understandable language enhances accessibility. However, it is important to acknowledge the challenges and ethical concerns in this domain. These encompass issues related to data privacy, potential biases in AI models, and the necessity to ensure that AI-based interventions align with established medical best practices. This is end of my presentation. Thank you for your kind attention.